Hello, friends, respected seniors, and dear colleagues. We are back again with episode 2 of The Pulse of Neonatology. You would be happy to know that the first episode was viewed by more than 900 colleagues. And today, in part 2, Dr. Ashish Mehta will be moderating. And we have got two S faculties in form of Dr. Sanjay Wazir and Dr. Naveen Jain, who don't need any introduction. Let me tell you, give you an idea how it started. From 2016, we have started online education. That was in form of text form. So Dr. Nitin Shah has termed it as a seminar. And then came this COVID. So at that time, Zoom platform came, and we went for online program on Zoom. So the COVID was viewed at that time by more than 2,400 colleagues. So continuing on that line, we have decided to help our colleagues, especially those who are practicing in a solo setup in periphery, where they need the help most. So our format has been from beginning to help such type of practitioners. And neonatology also till level 1 and 2 we have tried to cover, because level 3 and 4 becomes entirely separate domain. So today Dr. Ashish Mehta sir will be moderating this session. And today Dr. Nitin Shah is a social engagement, so we'll miss him. But for a change, again, the new thing which we adopted this time, normally me and Dr. Nitin Shah, we moderate. But this time we decided to do this thing justice by an expert. So we found none other than Dr. Ashish Mehta, who is a face of neonatology in Gujarat. So I'm very sure that our colleagues, they will enjoy this thing, they will enlighten themselves, and repeatedly also they can watch, because ours is a recording link will be available on our Gujarat Pediatrician WhatsApp group channel. Those who have not subscribed, please do so. And there you can find our previous webinars also. And let me acknowledge the help of Dr. Nitin Shine, all the scientific endeavors. Being a scientific chairperson, every month he comes out with brilliant ideas, and at times he prepares the cases also. I acknowledge the role which Dr. Nitin Shah has played since the beginning of this group, that is 2016. Now, not taking much time between the academics and you, straight away over to Dr. Ashish Mehta sir. Thank you.
Hi, good evening. Thanks, Dr. Ramesh Bhai, for the kind platform that you have provided. And I'm happy to see that more than 900 viewers were there for the last program. We focused mainly on the level 2 issues. And I remember that we started with a baby has just delivered and what care is required before baby is delivered and at the time of delivery. And then we are transporting this baby to the delivery room. We ended about the various kinds of formulas available or the various kind of milk option that is available which can be given to these babies. So we'll continue from there. The first question that I'll ask to ask Dr. Naveen, that which are the cases where you will think of putting IV line, whether it's term, preterm, IUGR, sick baby, not sick baby. But like in my unit, the fellow, when he puts IV line, the first question he has to ask himself is, do I need to put IV line or not?
Yes.
So what should be the norms for a level 2 unit to decide whether to put intravenous lines or not?
There would be only two definite situations. One, if a baby has hypoglycemia, which is not settling down with either breast milk feeding, and I would not hesitate in giving formula feeding if hypoglycemia warrants it before I start IV fluids. It is not only less complex or associated with less risk of injury and infection, it is a more wholesome food than IV fluid, even though far inferior to breast milk. The second situation would be less common in a level 2 setup where you have such a small baby, let us say less than 32 weeks in gestation, who we may hesitate in giving full feed on first day. Although we know of experiences from Dr. Sushma's unit in Delhi, where they have attempted giving full feeds to stable preterm babies on first day. We have not found the same success with most of our babies. Half of them would develop feed intolerance, and we do not have a dedicated breast milk bank to give donor human milk. Other than these two situations, I would feel that IV fluids do not have an advantage over. Of course, there could be unique situations like a severely asphyxiated baby, a surgical abdomen. These are obvious, and that's why I did not cite them.
Very nice. When very clearly said that there are only few selected indication where you talk about putting IV line.
Ashish,
And I fully,
Ashish,
yeah,
the better way to put it is where not to do it. Like which often get like, so done. So often it gets done because the child is probably on an oxygen or even a CPAP. It is certainly not an indication for putting a child on an IV line, even if there is a tachypnea of 60, 70 or whatever. There is like a child who probably has been born oft of like so-called birth asphyxia but does not have an HIE and does not have like any kind of a connotation. It's just that like there was some deceleration or and some resuscitation, for example a bag and mask for 30 seconds, certainly not an indication for giving an IV fluids. Third, you said any child who's more than 32 weeks, certainly not, and well baby, certainly not an indication for putting an IV line. Asymptomatic hypoglycemia in a baby, unless you've tried, as Naveen was saying, tried feeds, like is not an indication for putting in an IV line. And similarly, if there is a child who is admitted for jaundice, even if it is a relatively high jaundice at 2022, whatever, which is used to be a practice that we give IV fluids, and Naveen would remember that all children at that time we had to give IV fluids because that was a part of a study, but we know that's probably like not justified in the current era. So even if you have a bilirubin of 22, please give oral feeds, especially in a level 2 settings.
yeah, absolutely well said. But the question is that he said, Naveen said that like Sushma's unit, he tried in his unit but failed because of the tolerance was not there. And in absence of the human bank, the option was either mother's milk or formula, which may not be tolerated on day one. I'm going to day one. So what is tolerance? How do you measure that thing? Because to me, it is individual thing. My one customer said baby is well tolerated, then sister comes and there's the distance and she stops. So what is tolerance then? How do you say that if it is tolerated well? And if not tolerated, which are the points by which you said this is not tolerated? Either of you.
Yeah,
Okay.
then go ahead.
Sorry, Sanjay, you can take it if you wish.
No, please. Like you are my senior
Yeah.
always.
I mean, there is there is a very important question actually, Ashish, because the fear for NEC should be restricted to the kind of babies they would really not see. I have to confess that in babies beyond 28 weeks of gestation, maybe baby will vomit for 1 or 2 days, but that typical NEC fear which is there, which makes us stop feed completely, put him on IV fluid, is quite unfounded. Many babies who are given formula milk, they do get vomiting, they get abdominal distension. But this is not restricted to premature alone. Even term babies do that sometimes. So we may have to restrict feeding for a day or two. But short of that, two things which are not to be considered as feed intolerance. One is trying to aspirate a feed before the next one and finding a green color or a slightly larger aspirate than a few ml. These both need not, should not be done. Please do not aspirate the tummy before the next feed. This was taught to us all the while, so therefore many textbooks would still contain this content and the practices go on. It has become obsolete almost now. And second thing is abdominal circumference measurement. This became popular when feeding aspiration had gone away and something had to be there. But it is very subjective. Where you measure, whether you measure in inspiration, expiration, these are all going to be making incorrect statements. And therefore, unless there is some abdominal distension which a pediatrician can easily make out is surgical, there is vomiting persistent, 1, 2, 3, it wouldn't stop. clearly bilious vomiting, these would be only as feed intolerance. In all other situations, I think a serious effort needs to be made to continue feeding.
Naveen sir, may I ask one question? Because our colleagues would like to know that why initially we used to aspirate before giving feed and why not now?
Yes, very right, sir. That when we give milk to a baby, we expect that in hour and a half or two, this milk would transit from stomach beyond the pylorus and would not be available for a feeding tube to aspirate from the stomach. So it should have gone beyond the pylorus from where you cannot aspirate it back. And for the same reason, we thought we can't get a green color back because it's beyond the pylorus. But what we have found is that some secretion is there anyway. It could be the gastric secretion, and this 1 or 2 ml or 3 ml do not constitute a feed intolerance or aspirate. And what happened is when people were aspirating, the tendency to withhold feeds became so rampant that babies would not progress with feeding. So this practice of aspiration never saved a baby from NEC. It only resulted in delaying of enteral feeds. So in very preterm babies, not the kinds which they would see, it is believed that you can take much longer to empty the stomach, and you may even so-called regurgitate from beyond the pylorus and get some greenish color also in the aspirate. But that's fine print. But the point is that if you are going to get a single large aspirate of 10 ml when a baby is sick, lethargic, apneic, 34-weeker with abdominal distension, then you may say call the surgeon. But if you get 3 ml or 2 ml, and even if it is light green in color, I would still rather continue feeds than prick in an IV line and land up in sepsis and malnutrition.
Thank you so much.
Initially, the bowel movements are not great. Even for the full-term baby, on day one, bowel movements are not great. There is going to be some stasis, and some stasis is being aspirated. The fluid is aspirated, milk is aspirated, and then it is termed as intolerance. So that is a wrong sequence of the event that is happening. Forget about the aspiration. That's the reason that because of the stasis, the aspirates can be high. Ignore that. Just continue. More you give, more it will be tolerated. It is reverse other way.
Oh,
Rather
great.
than less you give, it will be less tolerated. It is more you give, more tolerated. It will be like that.
Great. So as Naveen sir said, the total picture should be taken into account and not simply aspiration. Yes, thank you, sir.
So then once we start for a baby, let's say 31 weeker and 1.1 kg baby, one unit is giving exclusive rastive feeding to begin with, because there's a time tested unit, learning curve was there, everyone is mastering the feeding technique, intolerance, picking up the small things early. But there are places where IV fluid will be started. The problem at the moment is that which IV fluid to start with, because most of the saline will be with 5%. And a 31 weeker 1.2 kg baby will not be okay with 5% dextrose saline or DNS 5%, which is 5%, 0.9% normal saline with 5% dextrose. So will you advise them to make it to 9% by mixing 25% dextrose into it? The level 2 unit where the asepsis may not be up to the mark. Sanjay?
So the point you're trying to make here, Ashish, is that like 5% is hypotonic and may cause little, problems with the hypotonic fluid, and 10% is likely to cause hyperglycemia and may result in hyperglycemia, which you do not want to go out with all that osmotic hyperosmolality. Now, given the fact that I generally say hypoosmolality is a bigger problem and 5%, so I would generally start. Hyperglycemia still can be managed, and we have still a large window. It's not like hypo, that one episode or two episodes of hypoglycemia are going to kill. So it's a sustained osmolality which is high over a period of time, which causes hyperglycemia related changes in the brain. So I mean, my recommendation generally would be to start with the 10%, and then you probably can, if you still are not able to get hold of this thing, then you can probably dilute it to, rather than straight away going for 7.5 or 9 or 8%, which becomes cumbersome at level 2 units. Start with 10 and then go back to 7.5 you feel that the things are not working.
Yeah, but Sanjay, it is either you start with D10% plain, but now we don't do that. We need to start with some electrolytes along with in a small babies. For a proton base is still all right. So
Yes,
putting some sodium in the market, 0.45% DNS is available, which is 0.45% half normal saline plus 5% dextrose. To make it to 9%, 10%, you need to add something into that. And in absence of proper aseptic precautions, you are adding the risk of sepsis by preparing and mixing the formula for IV fluids. Any clues, Naveen? Do you get my question?
no, not really.
Ashish, leave alone level 2. I think bacteria don't recognize the level of the unit. And sepsis rates are very high even if we mixed it under a laminar hood in our unit also. So I would get very uncomfortable if my unit had to mix fluids. I would rather change the flow rates, do things, but try to go simple.
Correct.
But which
10D,
fluids will
fine.
you select?
10D. And unless it is a baby who is some 700 grammer and gets overtly hyperglycemic, like 200, 250, I would stick with 10D. We don't add sodium in the first 4 or 5 days when they are very, very small babies, like 24, 25 weekers. But if it's a 31 weeker, by third day, we'll be looking at some sodium. And that's after monitoring the sodium and potassium. So, and not going into the finer details, I think if one word answer, it is 10D, unless the baby is happy. And please don't mix fluids if it can be avoided. It is a fertile soil for sepsis.
Correct.
So for 700 gram, what will you do then? I know level 2 it will not be entertaining 700 grammer, but the received maybe 900 grammer. Are you okay with
I
10% dextrose to begin with?
still 10D, still 10D, unless the baby gets overtly
But you will also
hyperglycemic.
give,
Still 10D.
for 700 grams, you will also give, protein and lipids also on day one itself.
Yeah. Yes. That
Okay,
seems to biologically balance out the risk of hyperglycemia, and I think mathematically reduces the GIR also.
Correct.
great. So that's perfect about the IV fluids. Question is again, we are coming to the commonest thing. Shall we start with antibiotics on this baby? Who's a clean baby, 31 weeker, 1.2 kg baby. We know that baby is gone IV line, and because of the IV line, risk of sepsis is always there. Shall I start antibiotic here or not?
So the antibiotic, this has been debated multiple times. Now, like there are two answers. One is an academic answer that we should not start with an IV lines, and that holds true for good units like you and Naveen's, like where you say, okay, you have enough confidence in your knowledge and your practice that you say, okay, this baby does not require an IV antibiotics. However, having said that, the reality, the gross reality is that virtually any child in maybe 50 kilometers from your unit, also Ashish, would get an IV line. So even if you go and tell them that it is not required, it gets done because the fear of losing a baby or a neonatal sepsis and the confidence they have in their unit is becomes overwhelming. So the practical way to look at an Indian scenario, again, I'm saying it is not the right way to look at it. If you start, ideally you should not start, but if you started, start with the lowest possible, like not like straight away cefotaxime and other thing, and you probably look at stopping it early. That is more important than trying to say, okay, because once started, it never gets stopped, like, but ideal situation, it should not be start for a clean baby.
Ashish, I would agree with Sanjay, but in one area we don't start. That is, we know that babies may be born preterm for two class of indications. One would be a preterm labor, whether it is preterm rupture of membranes or a leaking. These situations we would start, even if the risk is very low, if it's a asymptomatic baby. But if it is a mother who had eclampsia and the baby delivered and the baby is not sick, maybe some tachypnea, CPAP, I think we are 80% time not starting. Previously it was 100%, but now I have 5 colleague consultants and I love them. So if they start, I don't fight with them. But otherwise, if it is a no preterm labor just pregnancy-induced hypertension, maternal illness for which the baby was brought out, and the baby is just having only tachypnea or CPAP requirement, not very sick, we do brave not starting. And for last 23 plus years, we start only amikacin monotherapy. We don't start amikacin with ampicillin or amikacin with piptas. It is published, and both Srinivasa's unit we were discussing today also in Hyderabad, St. John's unit, they have been all three practicing only this. There is biological basis for it.
Correct.
We have done more than 1,000 mother testing for GBS in the last 2 years and published that paper. We did find GBS in the maternal vagina. So it's not that our testing ability was bad, but not a single baby was symptomatic. That is A. Second is that amikacin alone was an RCT was done in our unit against piptas, and again similar results. And unless there is meningitis treatment, cefotaxime has its own harm. So we are talking from three large unit experiences that amikacin still covers 80% of the gram-negative, almost all MSSA, and therefore, if it's an empirical antibiotic, if it is a very shocky, outborn, bleeding baby, then you are not merciful. But if it is just for the fear factor, that baby is tachypneic and premature and born through preterm leptal membranes, amikacin monotherapy, I can repeat that 5 times. Amikacin monotherapy, don't add ampicillin, don't add cefotaxime. It is very safe.
Yeah, but that is true that you are saying that you are very clear that these are for the units, they have got good aseptic precautions, good asepsis culture, and everything. I strongly feel that we can't implement this strategy all over all other units. We are practicing level 2 care.
Correct.
So I'll go by the what even Sanjay says that sick baby, if you're afraid, I will only add one thing to that. Take culture, you may not start antibiotic. Even if you start, take culture, stop ASAP as early as possible. I fully agree with the cases where simple PIH, clean babies, otherwise, because of the metal indication, preterm delivery, I will not be worried even in 600 grammer not to start antibiotic. Just continue the routine care, that's it. But in a given case of unexplained preterm labor, where patient has come from outside, where we are not, I'm not aware of the way the baby was handled at birth, or may not be knowing about any maternal history. In that case, take culture, start antibiotic, if negative, stop. And again, I fully agree with you that single antibiotic should work, but again, with a word of caution, all depends on the kind of unit in which you're working. We can't make the generalized statement. That's what I feel. Sanjay.
I agree with you, and my experience, because we've been doing this tele NICU with at least 12 other centers. It took me 1 full year to stop Rantac in one unit. Like, so it is like, so we talk about ideal situations on the Zoom platform, but exact reality is that even if you don't see, if I tell them मॉर्निंग तक वो बच्चा और किसी ना किसी एंटीबायोटिक पे होता है. सो आई स्टॉप्ड फाइटिंग दैट लड़ाई विद देम कि ओके डू नॉट स्टार्ट. I'd like, say, okay, very well done, you've started, but now I think it is time for us to stop. That worked better for me in, in convincing them. And I think, you have to give it to the people who are dealing with level 2 centers, because they are single man unit. They are going home in the night and may not have the liberty of having the residents observing and the astute clinicians available on call all the time. So you would probably have that fear factor, but let them give it if they are wanting. Ideally, they should learn from Naveen and say, okay, these are not the way it should be done. But if they're not doing it, maybe stop within 36 hours after taking, as you said, culture, because most cultures, if it has to become positive within 24 to 36 hours, it will become positive.
I'm not being idealistic, Sanjay and Ashish, but in a unit where there is no monitoring available and resources of qualified manpower is low, in fact, pushing an antibiotic, especially if you're pushing two of them, an ampicillin and gentai or ampicillin amikacin, is a wonderful opportunity for pushing in Acinetobacter or Klebsiella loaded in that fluid syringe also. So please remember that when we are treating 90% of babies with no infection and treating our fear factor, at least some of them have an added risk of getting infection from this antibiotic pushes. So this
Correct.
is something we need to be aware of, that these are unclean pushes in an unclean.
Correct.
There are few good practices also which can go to liver unit rather than talking about asepsis, talking about starting antibiotics, stopping antibiotics, culture. Even places are there, the culture phases are not available. For example, take 60 kilometers away from this place from where I'm working, cultures are not there, are not done in pathology laboratories. There are 10 pathology laboratories are there, but cultures are not being done. So culture will be taken, will come to Ahmedabad, and then they'll get the report. That's the reality. The only thing that works is the supervision. At times, because of one or other reason, nursing staff or paramedic staff or our junior doctors, maybe non-allopathic doctors are there working at the peripheries. They forget about washing hands and they forget about following proper hygienic practices. Good supervision. I'm monitoring one unit from my place, which is something like 300 kilometers from my place. Only supervision has decreased sepsis rate. There is no use of antibiotic for last 3 months. Simple supervision. One is supervising other is supervising third. And daily the reports are being sent that this is about the culture reports, infection reports, CRP reports, everything. For 3 months, no antibiotics. Only one thing which has worked is supervision, proper supervision day in and day out by senior staff. Now, who to label senior staff? Again, difficulty, not easy, but still is happening and is workable thing. So again, it goes by the culture and the rules that one is following as far as antibiotic is concerned. Then next would be that once they are on full feeds, Naveen, when you start?
Yogesh, Ashish bhai, can I come
Yeah.
in? Just
Yeah.
now, this is very interesting what you said, Ashish bhai. What about first question is what about involving as a caretaker in our NICU, one of a very sensible relative, if because at times what we have experienced in periphery that during Satamatham or during Janmashtami time or during Diwali time when staff is less, then by involving the staff, of course, we have to take sufficient precautions, apron and everything. But that many of our colleagues said that has helped them a lot because a sensible relative, because he or she is more involved because this is their own child. Second, sometimes there is unnecessary pressure from gynecologists that this is a precious child and please start antibiotic. And third, what Dr. Jog says that any illness that starts ceftriaxone. So in NICU also, many of our colleagues, they straight away start antibiotic and at times it is meropenem also. So please guide all of these three as far as these three queries are concerned. 3 points rather, not queries.
Sanjay.
Yeah, so I think the first point was ceftriaxone. Is that right? No?
No, involving relative. Involving
Involving
the
the
relative
relative in the
as a
care
caretaker.
of the child. Now, it has own plus and minus. I think, one, I would not really be able to give a clear answer to that question, but I can also see what are the pros and what are the cons for this particular, habit. One, let me first talk about the cons. Now, when the relative is there, and especially beyond someone beyond the mother, the staff becomes very uncomfortable. So you need to also look at your own staff, because anyone who's they feel it as an intruder. For a doctor it might work, unit it might work, but the staff feels uncomfortable. Second, all said and done, that increases rather than reducing the work for because there, since that person is not kind of care to handle the baby, if for every small blip, every small alarm which may not be relevant, he will go and ask the question to the staff, and then the care of the really sick one gets really hampered in that case.
Correct.
Now, the third thing is that, of course, there is a medical legal implication for doing such a thing, because if tomorrow a child collapses, for example, for anything, you are medical legally liable because you have employed someone who's not trained to do that work, even if it is a relative, So that is like, a problem. On the other hand, of course, like you say, okay, the extended family care and family care and the extended family care, that can also help. So once in a while, for getting smaller things like a diaper change, like a, making a feed, those things in circumstances you would do it. But when you get new people in, when you get new staff also into the NICU, you also risk the risk of infections also increases as such. So I mean, I would, if others have a different view, I probably would take it later. Yes, Naveen wants to say he's happy to do it.
Our experience is 180-degree opposite. From the year 2004, we started universal 24-hour access to parents, both parents, in the NICU from the first few minutes after we intubated, put the stickings, and allowed the baby to stabilize. It is Dr. Anish's 3 years research after one pilot study for whole year. The first year, we found the same resistances that you mentioned. The hospital infection control committee was uncomfortable. Nurses were intimidated. Parents were observing some alarms. And except possibly my personal madness at that time, everyone else felt this is just getting beyond human understanding. But now it has become such a culture now that we would be having a 24-weeker in the NICU in the incubator, and the father would be standing touching the baby from the first hour after the surfactant is delivered and the lines are in. The next day, the mother would be giving tube feeds by herself, not diaper changes. Or even if the 2 ml of colostrum is there, she is giving by herself. And by 4th or 5th day, all the tube feeds in the unit are given by the mother. And before you counter this as a Kerala phenomenon, this is not there in rest of Kerala. And we did have occasional parents who felt either overwhelmed by so many alarms and sick baby. There were occasionally once in a year where they were a little angry with this not being done right and that not being done right. But it is more likely that they would be angry if they just kept outside the unit and not shown what's happening. Our infection rates have dropped dramatically after parents got involved because they are more likely to wash hands than we do. They are colonized by healthy bugs than what we are. And they participate in more than just touching and calming the baby. And they are not replacing our nursing staff. That is the one difference we have. They're supervised by nursing staff there. They are fully a part. Nursing staff doesn't get any leeway because there is a parent inside. But they and they are sometimes now they're available that, okay, there are 2 other sick babies, and then uh, they say, okay, you continue the feed. I'll just go and visit that baby and come back. But they're there, monitors are on. I know that this may not apply to all units, but at least a few things I can say for sure. They do not increase sepsis rates. Litigation rates are equal on both sides. And luckily, we are currently not, I don't know what's happening just now back home, but till now, there is no medical legal case because of a parent watching what we were doing. And lastly, they are not replacing our staff. They are just joining our staff.
I fully agree with what Naveen says, Sanjay, that yes, presence of father, mother, parents, not other relatives, make huge change in the overall management of the babies. And they are not replacing the staff, but they are actually they become friends. In fact, that is what I observed. Except few instances, it becomes a lot of like a family. They know the staff well. In fact, they start taking care of staff, nurses. That have you eaten? Go for food. Come back. Then she will go. They will make the tons for going for the washroom, for going for the food, because someone wants, a mother wants someone to be there, so to be there with the baby. So father, mother, and the sister, they make turn by turn for the food or for the party feeding, for the changing nappies. Everything is happening. It becomes such a good chorus. It always gives a good feeling. Occasionally there are
Yeah,
complaints.
I think the question here, the question which Dr. Ramesh was saying, can the relative or the staff take over the nursing role? Like, when
Uh,
they
Nah,
said,
they
no,
can't. They can't.
no, Sanjay sir, no. My point was that can we allow them, because what Dr. Meenol has written, what Dr. Ashish sir is saying, what Dr. Naveen sir said, what this I have also been doing in my NICU. And when I have what I have seen, exactly opposite whatever you said about medical legal issues. In fact, I have seen them witness to what we are doing very closely, and at times it takes away our pain of counseling also to them, because they are there continuously. They see that how many times we visit the baby, what we are doing. Suppose if they are outside and something suddenly happens like apnea or something, then I have seen that they are doubting that till a few moments back baby was well. So over the period, of course they are not replacement to nursing staff, they are there to facilitate, but personally I would go for it in level 1 and 2. Thank you, sir.
And Sanjay, it is been seen that the decides, color changes, feed intolerance, those what they start noticing themselves. So while doing KMC, for example, if baby desaturated, then she will tell that, sir, it goes below 60 and I put him back or started oxygen.
No, no,
So that
I
means
think probably we're talking of two different situations. One, we're talking about should the mothers be allowed 24 into 7? The answer is yes. Should
yes.
what we're discussing, can they take over a nursing role for short duration
No.
when
No, they can't.
Janmashtami
No.
or
They can't.
whatever festivals you were mentioning? I mean, that's the other part of it. Like, so I would be skeptical about they taking over a nursing role as a
Yeah,
add-on.
right.
It's fine, but as a replacement may be a challenge. But then, of course, every unit has their own ways to handle it.
Yeah, fully agree with that. That's fine. So the moving on to next, that yes, let's quick question. While doing KMC or in the unit, do you allow mobile? If the parents are visiting, do you allow mobile in the nursery? Very interesting question and practical also. Naveen, do you allow,
Well,
and Sanjay?
answer it straight away because we have a policy for that. That we have a tray kept on the nursing station, and we politely ask the parents to leave their mobile phones in that open tray on the nursing station. They come very diligently, leave it there, go to their baby. They feel respectful that they're going to the baby without the mobile phone there. But if they ask us that they want to take a photograph or a video because they want to send it to the husband who is abroad, then we tell our staff would hold the phone and they would do it for you. So they pick up an image or video which is not uncomfortable, ugly, and things like that. Similarly, it is a ritual for us to take a photograph or video of the baby, sometimes both, of a newly born baby who is in intensive care and the mother is still in the recuperating phase, and we want to tell her that your baby is fine. We want to have you start pumping milk. Then we take this photograph. My resident does that. They take a photograph and video and goes to the baby. But although it should have been that we doctors also should have put our mobile phones into the tray, we don't do that currently. That is very honest that we are not being honest. But parents, they leave their mobile phones in a common tray for the reason that they may carry infection, is what we tell them. But basically, it'll be very nasty. We know that they could be wanting to take pictures and videos which can confuse them, especially when a baby becomes sick and it can be used. And with the social media thing, it can be a drama. So we don't allow them to take their phones and into the baby care area.
Your voice is not audible.
Let's come to the more relevant thing now. Once we are full feeds, when do you start with the multivitamins, B folic acid, vitamin D, calcium, all this thing, Sanjay? At what level of the RT feeding or gestation age or weight wise? Is there criteria that you follow?
In terms of
Starting multivitamins into these babies, apart from rice to feeding.
So generally, we generally start once the child is on a full enteral field, especially in a stable baby. We do not think that there is an urgency. The first thing for us is to establish the feeds first. And once we establish and the child is on a feed, then you can introduce the vitamin D and of course the multivitamins also, depending upon the gestational age. For the babies who are on only on the human milk without the human milk fortifier, then those are the babies who get onto the calcium also, and you continue till 40 weeks post menstrual age. And vitamin D, we all understand that probably we need to give it for 1.5 years again. Multivitamins generally, like it's a tradition. I do not, if you look at an evidence, I do not have a very conclusive evidence that why you should be continued for like a month afterwards also. But that's a tradition because we think that the preterm requirement of minerals is slightly higher, and that is what we also tend to do and continue till at least till the child is around 3 to 4 kilos in weight, and then be treated as a term baby. Iron, we generally for big babies say 34 weeks and above, they also need iron, but generally start at around 2 months of age because their iron stores are slightly lesser than the full-term babies. And of course, that less than 32 weeks is not what we're discussing right now.
So you start iron, not in the nursery level 2 unit, maybe 1.4 kg baby, 34 weeker. When will you start iron?
No. See, two different things. As I said, 34 weeks baby who's and 34 and above. So generally, the recommendation is that you can start anywhere between 2 weeks to 6 weeks. Fair enough. We generally start like everything because invariably at that time the children also have a functional gastrointestinal disorders. And 34 weeks and 1.1 is a different baby than 34 weeks and 2 kilo baby who is a different baby. So 34 weeks and 2 kilos, we generally are happy to continue and start their iron at 1 month once the functional gastrointestinal disorders are kind of okay. For smaller babies, we generally 2 weeks and 3 weeks, we probably and on all feeds, you probably would start with iron at that time. Not one single value that you can say okay for works for every baby.
And since you're opening up the whole thing about the iron, we know that ideal iron salts are not available in the drop forms. Am I right, Naveen and Sanjay, in the market? Ferrous sulfate, ferrous gluconate, yeah.
Before the preparation, we do start iron at 1 month, and
1 month of
just
age.
give yeah, for
Yeah.
all gestations, for that matter, even 27 weekers to 34 weekers. And we have one biological basis for that. We have done two very large data collection for a long time and found two interesting things. One is that when we started babies, the measurement of their what we call as indices, your MCV, MCH, MCHC at 3 months, we were trying to compare 2 weeks and 6 weeks iron starting in these babies. Hemoglobin and indices were just the same. But the iron measurement indices, that is your iron levels, total iron binding capacity, all those things, was significantly low in those babies who got late iron. And there is a biological understanding that whatever iron your body has gets used up for making hemoglobin and blood first because that is important for living. And it's possible that the brain is not getting enough iron, then this doesn't seem to be reversible. It's a what's called as critical periods. That even if you give it back later, you can get the hemoglobin back, but not that window which you have lost. So this is just this is well recognized also. It's not just our personal idea. Now the second thing about preparation of iron, the only way to know whether you're doing right is measuring the iron levels at least a month after you treat, because it's just not about the preparation. Babies, unlike adults, you can't tell them to give an empty stomach. They're feeding very frequently. Very often they spit it, so parents are forced to fix it, put the drops into a spoon or palada of milk and then give it. This limits absorptions. And there may be erratic absorption per se in everybody, not only in newborns. And therefore, the way to measure whether we are doing good iron is not by measuring hemoglobin or MCV, but after a month you must measure ions. There's a caution that if the baby has been transfused, then measure ferritin levels before you give iron. It can go into even 900, 800,000 ferritin levels. So more than 300 in a transfused baby, please avoid iron charting in urgency. So to sum up again, for practice learning, a preterm baby, we would prefer to start iron at 1 month. We are aware that this is important for brain than for the hemoglobin. And second is that if you transfuse the baby with RBCs, then measure the iron levels, ferritin levels before you start.
Yeah, normally what is now ESP's and recommendations that look at the ferritin levels.
Always.
If ferritin levels are high, don't give iron. If low, then start whenever required. So at 15 days in a very small babies, try to look at the ferritin levels and act accordingly. And you are right. Ideally, ideal salts is still not available in the drop forms. Syrups are available but difficult to measure and difficult to put in the baby's rice tube. And empty stomach at times is not possible. So only way by which you can monitor iron is either look at the hemoglobin level or ferritin level, by which you can judge what is given is adequate or not. So from there we'll come to the OPD. Now this baby is growing well, but many babies don't follow the charts. In front of you, these babies are not growing and they are becoming EUGRs, extrauterine growth retardations. So the common method would be that increase the feeds 150 to 170, 180, keep on calculating calories and see whether they are escalating the chart, they are jumping on the charts or not. There are still few which will not gain weight. You look at the hemoglobin, you look at the calcium, you look at the metabolic workup, everything is fine, but baby doesn't want to grow. This might be 10 out of 100 baby that is there, which are VLBWs, which are there in your nursery. And then you look at the HMF, that HMF is added or not, how much is the calorie, how many is the protein. In spite of all these things, when the places were given for to take the exams, always look at the calorie chart, look at the protein chart. At times, in a babies who are not growing, in spite of every number is right, still baby is not growing. So which are the things that will come to your mind, Sanjay, that you increase the feeds, you put HMF on, feeds are being given properly, calories are adequate, but baby is not growing. What shall you do?
Yeah, I think this is like, this kind of a situation we need to relook, because the problem could be 90% is in the feed part of it, whether it is latching, whether it is like taking enough
Hey,
calories.
this is not rice to feeding. This is on rice to feeding, growing babies, but not meeting the charts or not following the charts.
It's the OPD baby, IPD
Yeah,
baby.
IPD baby, still in the nursery.
And the child is like, and you're giving protein to the tune of around 3.5 to 4 grams.
I want to, but at times it is difficult to go because I can't go 180 ml per kg per day or beyond at times because baby is not tolerating it well. Baby start refluxing, baby starts vomiting. So I stay at 180 ml per kg per day. And with that exclusive breast milk HM, even if I add, I go up to 3 to 3.2 gram per kg per day of protein, which may not be adequate for that baby to grow because we know that you can go to 3.5 to 4 gram per kg per day and we don't have extra protein to add into the milk. What shall we do?
See, there are two things to one consider, because generally I would revisit all those things that you just looked at. For example, cold stress, anemia, like occult infection, an occult UTI, an occult fungal infection, a renal loss of sodium, which is causing hyponatremia, a metabolic acidosis. Like, these are the commonest things that you need to look at, revisit, and say, okay, there will be some problem somewhere. If you are probably, you're talking of that you're given calories to the tune of 140 kilocalories, and 140 kilocalories is a huge for a preterm, because it requires somewhere around 120 to 140. And if you're given a protein which is 3.2, I mean, ideally I would want to get it to 3.5. There are monocomponent proteins available now in the market also, which you can add as a monocomponent HMF, like, that one is a protein to increase. And if still that is like a problem, of course, then I mean, sometimes we end up giving a formula as like as to substantiate whether this is related to it may defy logic that why formula works, but probably I think it is the sodium balance which gets established better with a formula in some cases. I have seen some people even adding soda bicarbonate or a 3% NaCl to increase the sodium retention as a cause of feeding this thing. But generally, I would probably, rather than adding something to the breast milk, I'll probably do one formula and one breastfeed. But again, as I said, some people where the weight gain does not happen, they empirically put 3% NaCl or soda bicarb there as well.
What do you do, Naveen?
I would go with first part of what Dr. Sanjay said, is to make sure that I'm not dealing with pathology. If I have given full milk, pathology like continuous vomiting, polyuria, or an underlying urinary tract infection, fungal infection. If these are not on my card, then in a baby who is still into what is called as recuperating phase in the ICU, if I've done my job well of giving milk, I don't think HMF or changing formula or even for that matter giving sodium will help, except in those very tiny babies where sodium losses are really an issue, like those sub 28 weekers. But otherwise, um, I think I would just wait out on this baby because many times they're just between their acute phase of illness and not yet in the growing phase. If the same question was asked to me in the baby who's going home and in the OPD setting, then I would really look at what is the mother and father's body structure and the skin fat of the baby, what it called. So this morphological presence of skin fat, whether even in a baby in the ICU may see a cheek, these may suggest that negative energy balance is not such a concern. They may be just small built babies who are defined to follow the chart that we have made. But uh, I don't have very strong belief that adding HMF, formula, sodium, soda bicarb will really give them growth. It may give some number gain, but it is not growth. And if you have reached full milk and the baby is accepting it without vomiting, I think just leave him, let him enjoy life.
Okay, that's great. Yeah, okay. So let's come to the OPD part. Now, these babies have come to the OPD, and there are so many things that is well, okay, let's before the OPD. That now we have newer charts for the jaundice, Sanjay. And we are in fact we are all right with the old charts. Now, what was the rationality to come with a new chart, number one? And has it do you follow those? And if yes, has it changed your practice?
See, not necessarily that, when you decide in an OPD, yes, the newer charts would be of value for us, but we generally use a bilirubin calculator because it gives easy for us to show it to the parent that this is something which is required or not required, because we open that kind of a bilirubin calculator in front of the in front of the parent to convince that this is required. More than the talking in terms of charts where we talk of bilirubin as a number, we need to understand the pathology behind what we are talking, rather than, because I see today somebody came with a 34 weeks baby and said, okay, my jaundice is 17, and the one of the charts he saw was the term baby chart and said, okay, this is like completely irrelevant. Whether we are dealing with an HA baby, whether we're dealing with an ABO incompatibility or RH isomerization, which day we are talking about, all that makes a difference when it comes to interpretation. So I mean, I understand that charts are a good way to help NICU units, but I think it is important for all doctors to understand the pathophysiology behind the jaundice before deciding whether what kind of a therapy, or do we really need to go for a therapy or not.
Yeah, but has it changed? What is the difference in the old charts and new charts? Why new charts?
I have no idea about the new charts, why they were devised, but maybe Naveen can answer.
No, there is a academic part to that answer, that the intergrowth charts for growth or new charts for jaundice have been based on probably better designed studies. And when you come to new jaundice charts, they are again based only on consensus. Nothing is based on whether kernicterus became less more, or whether because all are looking at centile levels only and saying beyond 95th centile, I need to get worried. Now I will go with Sanjay clearly. I would always look at first, does the baby have any encephalopathy? I think any jaundice, you need to write that down. Is the baby feeding well? Is he active? Is he passing stool? Is he not losing weight? And of course, the common things that not having an ABO RH setting, not having a large hematoma somewhere. If these pathological things are not in early uh, term or late preterm, if these pathologies are not there, then the bilirubin value chart probably helps us to become objective. But none of these charts can guide a pediatrician or a clinician better than his clinical presence. Very helpful for a team to work, to be having a framework to not miss out or overtreat. But these jaundice new charts have also included some caution on something called neurotoxicity risk factors,
Yes.
which clearly talk about trying to guide us that which bilirubins may be more dangerous. Most of it is a common knowledge to most people, but it becomes a reminder checklist. Okay, this is a sick baby who was sick in the last 24 hours. This is a baby with asphyxia. He's having an RH or ABO incompatibility, and therefore the same bilirubin may climb to a dangerous level. So the bottom line, I would go totally with Sanjay. First place the situation. And if you are too busy, you are seeing too many patients and you can't make a counter check on all of these, you have 100 babies to see in a public health facility and you're not sure about reliable history of all these questions that you want to know, then make sure you're not having any signs of bilirubin induced damage and feeding is happening well. And lastly, use these charts to make sure you're working on an objective platform that make sure we make less mistakes. That's all it can be.
Yeah, the main difference is that they have considered the neurotoxic risk factor number one. And number two, if you look at the X line, X axis, they are hour specific. So they have got 12 hours, 24 hours, and right up to something like 7 to 10 days, they extended those charts. So like unlike the previous ones where the gestation was 35 plus, here you got for each gestation there is one line or one centile, and that's bigger. There's another difference. So first is they are considered neurotoxic risk factor. Second is it is lasted for maybe 7, 10 or more days. That the x-axis is showing the chart is can be plotted for the bigger babies or older babies also. And third, as I told you, that it is gestation age, for each gestation age there is one centile. So like previously you got only three, 35 to 36 plus 5 6, 36 to 37 and 37 plus. Now I got 35, 36, 37, 38, 39 plus. There are 5 lines in each charts. So that's major difference. But having said that, the problem for the level 2 unit would be that plotting is not that easy. For example, that bilirubin level itself at times is not possible. So in that case, do you advise that they should get bili check or transcutaneous bilirubinometer in their OPD to at least measure the bilirubin levels in a busy OPD, as I said, 100 plus OPD, and you do not have any access to the lab to get the bilirubin level that easily. Will you recommend TCB levels or TCB machine or bili checks?
So we do it routinely for
TCB.
all.
Yeah.
Sorry, you go ahead.
Wait, please after you.
So we do a TCB for all babies, like, because it is good to rely on your clinical judgment, but we also understand, like, sometimes we are seeing patients in the dark room or probably even a lighted room, like where we are sitting right now is not the right way to look at a jaundice. At that point of time, it should be seen in the sunlight. And of course, like, by the end of the day, I may be tired and I may overlook this thing. It may be cold, we may not open. So for so many factors, and there is a clinician's bias also that comes into. For practical purposes, if you have a busy OPD, it may be good idea for you to invest into a transcutaneous bilirubinometer, having understood that there is a limitation to a transcutaneous bilirubinometer and it cannot be used, like, it has a good correlation when the value is somewhere between 5 to 15, But if it is crossing, say, 14 or 15, and if you still think that the child is like, on only day 2, day 3, or day 4, where the bilirubin levels are still rising, at that point of time, it may be worthwhile for you to contemplate a blood value for those. So it helps only in deciding which babies you need to go for a prick, and reduces the error on the side of the patient, on the side of the doctor in a busy OPD for sure.
Naveen?
Yeah, I go every word with what Sanjay said. If room light is not good, this helps you. Subjectivity is taken off, pricks become less. But ideal use is in the first, second, third day, when you're expecting values maybe less than 10, 11, 12, and there you kind of don't want to miss even those low values. But when you're seeing a baby on 5th or 6th day in the OPD, a value between 11 and 15 doesn't matter. And what you're interested is in 18 or 20, and this machine cannot be used for that. I have been fighting a battle with my system because even on 11th and 12th day, they will just put it on the head because every parent is happy that something has been done with a machine. People also love machines more than human beings. Even the parents like that. उनको अच्छा लगता है, वो कहते हैं वो डॉक्टर तो रखते हैं, आप रखते ही नहीं हो, सिर के ऊपर इसको बिल्डुबिन ऐसे ही देख के बोल रहे हो. So I have last week only requested my colleagues to stop taking it to the OPD assessments, because beyond 5th and 6th day, the values which you're interested in are in 17, 18, and 19, not in 11, 12, 13 anymore. And if your clinical judgment says that it is 17, 18, 19, then do a blood test. Be sure. But in the first, second, third day, it is wonder. It really reduces subjectivity. It prevents you from missing a baby who's getting early onset jaundice, which is crazily rising. It takes away subjectivity and light factors. There was a question on calibration. Any machine requires calibration, but the requirements have not been set as high, maybe once in 6 months to once in a year, but not more than that.
And will you rely these TCB machines for the dark skin babies? Is it reliable even on day 1 or 2 or 3? Is it
It works
reliable?
well. It works well. I
Yeah.
think
So each
we are
of the
living in part
TCB
of the
machines are
country
good to have it, but beyond
where
50, one need to remember that it is not reliable. And 50, 15 or 17 doesn't matter. If it is more than that, yes, you need to ask for the lab test. TCB will not help. Only the in my OPD also what I have seen is that for the parents it is very useful even for counseling purposes. Even if I see the baby is really dark yellow and it comes very high, there is a reason for me to explain to them that, or for them to believe that yes, this high means in the machine means definitely bilirubin needs to be checked. So that helps in counseling part also. And in that case, I very strongly feel that for those busy pediatricians seeing the babies in their OPDs, they should get TCB is not that very high costly also. It is worth using it. It saves so much of time and saves so many babies, or the saves so many baby unnecessary to go for the lights by looking at the colors we put on the phototherapy, which will be avoided by using this machine. So that's great. Now, coming to the another issue with the bilirubin, that a lasting jaundice beyond 15 days, we all know it's maybe breastfeeding jaundice, nothing great about it. But how do you go about it, some Naveen? That mother is sitting all the time looking at the color. 15 days, I'll say that not to worry. Continue the breastfeeding. Baby is gaining weight, thriving well, looking around. Everything is fine. But that color and the tinge will make them change the doctor. Window shopping starts, and you as a person, you feel that this is not the way, because ultimately one of the colleague will prick the baby and will tell that, oh, it is 18 and this is something high and blah blah blah. So many things goes along with that. Syrup Gardenia started. So many things goes along with that. So how do you tackle those kind of situations which are not very uncommon?
two criteria only. If baby is gaining weight, baby is passing clear urine and yellow motion, then I don't test the values either with TCB machine or with bilirubin testing. And I'm thankful to my other friends who test it, because then the value comes up and admissions increase in our unit. So then they invite, but we still don't do all the lab tests. We don't give phenobarbital. But then they'll end up getting some phototherapy at a funny day of even 10th and 11th day.
Yeah.
It does happen, I would confess. But in my chamber room, if the baby is gaining weight and passing a clear urine and yellow stool, I tell the parents I'm seeing a yellow color. It was expected to go. It is not harmful. If you see it after 1 more week, please come back and show me once again.
Sanjay, now this baby has come to day 30 of life. Naveen had seen this baby on day 18. He has counseled them well. He has written on the case paper that baby is thriving well. Parents are explained, yellow colored scene, continue breastfeeding. And now this baby is coming to you in your OPD at 33 day of life. What will you do?
See, basically, as Naveen said, this is like, as you said, this is a breast milk jaundice, and we know this is going to last for approximately 2 to 3 months in some cases. This is probably that Gilbert kind of a phenotype which tends to persist and should not be a cause of concern both to the doctor and to the parents also. But at the same time, one would need to see that we are relying on mothers saying that yellow stools. At 3 to 4 weeks, I would probably at least get a serum direct bilirubin done to see if I am not missing out on a neonatal cholestasis, because that is something that if I miss out, I'll probably cause more harm to the child than to the. If that is there, and you explain to the parent that I'm not even looking at a direct value, total value. I'm just looking at a direct value. And if one of the values any time after 3 weeks is done, which is normal, then I'll say, okay, let's meet after two months when you're due for your your vaccination schedule.
Great. So we are very clear that all of us will be doing that. Don't stop breastfeeding. But then few of the colleagues would like to challenge that statement, stop breastfeeding, start Cardinal, and all those things happens. Now, coming to the another controversial thing would be about this constipation or not passing stool. A baby mother comes with a complaint that my baby is passing with great difficulty, baby is passing stool, and maybe every alternate baby is passing stool, cries a lot, baby is on exclusive breastfeeding, otherwise gaining weight, but that passing stool is not regular. How to tackle this kind of situation, Sanjay?
So generally, first we need to make the patient understand that the breast milk is like there is no fiber; it is mainly going to absorb. So it could have some children who are passing once in 7 days, also once in 9 days, also, and there could be children who may be passing a couple of times in a day, also, which is 70% water, 30% granules. But other people could be once in 7 days. So just the daily passing, which is like considered the right thing to do in our Indian society, is probably does not apply to the infant. It's like, and most parents can understand that, so it's not a big issue. It is the problem when the child starts struggling, and especially the condition called infant dyschezia, where they would probably struggle to pass stools, that and they're crying and howling, and then they start pass stools, and they get better after crying for half an hour. So they also interpret that as a constipation. And again, it is important for us to talk to them about that this is probably not a constipation. However, having said that, like certain formula fed babies would have really hard pebbly stools, and after you've reasonably ruled out a Hirschsprung disease based on a clinical examination and a PR examination, if required at all, if it is hard stool, maybe a change of a formula if the parent, if the history is there in such a child. If the child still has a hard pebbly stools on a breastfeeding, sometimes we think that this may be a cow's milk protein allergy, where the mother consumption of a dairy may be passed on to the baby, and in that scenario, sometimes stopping milk in such babies can help. And I'm talking of only the breastfed babies who are having it. Most of them would not have, but those who have, and of course they're
Stopping mother's milk products.
Milk products, if the baby is exclusively breastfed and still passing pebbly stool, then you're ruled out. Other causes, like for example, an anterior anus and a Hirschsprung disease, all those things that you've ruled out, then you probably would need to look at, like, that as a distinct possibility, often ignored.
You were saying anti-RS, what did you say? Please clarify that.
Sorry?
Apart from Hirschsprung, what do you suspect?
Anterior anus, the
Anti-NS, okay, I
analog.
got it. I
Yeah.
got it. Okay. So that is not uncommon thing that people will start using enema or the suppository or lactulose. They get tired. The mother is so much panicky or so much complaining about that my baby is struggling to pass stool and end up with some or other medications. Writing on the prescription that no medication is required. Will it suffice? Because they want to do something for the baby. Baby is struggling to pass stool.
Sorry,
Ashish bhai,
I could not. Sorry, please. I could not get the
we do not
question.
write the diagnosis as constipation. We write it as, I coined a new word called infrequent stools. And I go every word with what Sanjay was saying. 7 to 10 days is not at all uncommon. And of course, we will have different ways of communication to different people. But I started counseling them at 4 to 6 weeks visit that this is coming. Because almost it matches with the vaccination date, and parents think it is related to the vaccination sometimes. That 4 to 6 weeks, I ask them, is the motion already infrequent? Because I know it's coming, and then they are better prepared, number one. Number two, medications have zero. I'm very happy if they change the doctor and go to another one and let the person start, because my conscience doesn't allow me to give either a soap or another suppository. And I give them a date also, that the last date of the next month when the motion would get daily again. So if it is today, I will say July 1st के बाद July 30 के बाद होगा, तब तक एक हफ्ते में एक ही बार जाएगा. Please bear with the baby. And I tell them that the only person who is not uncomfortable is the baby. Everyone else in the room is waiting every day. It's not going to happen. Don't hold legs and wait. Don't apply anything. Don't pour water, and just let it be.
Fully agree with what you say. What I explain that baby passing stool as many as baby is being fed, that is normal. That is one extreme. Passing once in a week or twice in a week, also another extreme, which is normal. As long as baby is not passing green vomit, distension, and not passing through, this tract should not be there. But the rest of everything is fine. Just continue feeding the baby. And then I always ask them, who has the complaint? Is that your complaint or baby's complaint? Baby is looking around, playing around, gaining where the mother is, and the people standing behind mother, they are complaining. So this answer will suffice who is in trouble, whether you or the baby. And then they realize that it is the baby, it is not the baby, it's the mother who is at fault, or mother is complaining. Anyway, so Ramesh, shall we continue, or do you want us to stop? And there are many other OPD related issues.
No. We have to continue till our stipulated time, that is 10:30 p.m. And
Okay.
we'll definitely go for episode 3. So please, at this pace, this flow content is excellent, and I'm very sure that we need more of it. So please continue till
These two
10:30.
experts are really putting a lot of efforts in
Absolutely.
ensure that right message is being conveyed. Thanks to both of you. They are yawning in between, but then still looking tired also. But
No, but Ashish bhai, I
beg
must
your pardon.
compliment you, sir.
Because Sanjay has got very busy OPD. I don't have a busy day in NICU also. So Naveen has got whole day be in the workshop, that I also know. But I beg your pardon, need to continue with that. We'll finish.
Ashish bhai, today, and in fact, last time also, you have covered so many common issues, which in day-to-day practice, I mean, parents, due to bombarding from parents, we as a pediatrician struggle. But today you have touched upon all these points in such a lucid and the manner in which parents will definitely be convinced. So
Okay,
please
thank you.
continue. Yeah.
So let's go on to another thing about the cry. And really at times babies cry, mothers crying, nani and dadi are crying. Ultimately everything comes to your unit or in the OPD, that excessive crying day in, day out. You try everything. You know that this typical infantile colic, and we know that colic doesn't need any medication as such, except few anticolic drops. You can't do more than anything more than that. For exclusive breastfeeding baby, you can't change the formulas also. Those who are on the formula fed, you may try different formulas to make them little bit comfortable. It is a time only which helps them to get relief of the colic. How do you tackle this in your OPD, Sanjay? A 2 week old baby, exclusive breastfed, gaining weight, and now mother complaining that baby has got uncontrollable cry, and it makes life difficult for the mother. How do you tackle that?
So before that, an anecdote when I was in PGI. So whenever somebody would say it's a colic, I used to say "ठीक हो जाएगा," and I would used to walk off. And not understanding the pain, the agony that the mother is going through. Today, somebody came from Delhi to Gurgaon just because shown two people there, and they are exactly the same कि अपने आप ठीक हो जाएगा 6 हफ्ते पे. But they are looking at a solution. I mean, if you have a newborn baby and is crying in your wailing, is the most distressing feeling for the child, for the parent. Now, it is important for us to understand that like colic is, we all understand that colic is a disease which will go by 3 months, 60% will go away, 4 months, 90% will go away. But the parents are asking what to do for that length of time. Now, it's important we understand there's no solution we can offer, but at the same time, we need to keep them busy, like, busy with something so that they feel that I'm doing something. Just saying that, okay, it will be okay, it doesn't happen. Like, so generally, my recommendation is generally for the parents is to, you feed for a duration of 10 to 12 minutes. Maybe you need to burp the child and keep the child on the shoulder and move around, and for 5 or 7 minutes, like I don't know whether they work or not, but doing a little bit of a massage on the tummy is like with the understanding that, or using a cyclic movement, using a white noise to help using Amazon or tap water, or probably using Alexa for the white noise, these things. And something not works, but at least for my child it worked immensely, was a car ride. And you can try so if your child is crying, you will see that they're rushing to the hospital, and the complaint they have is that कि पूरी रात रोता रहा या जागता रहा, इमरजेंसी में ले गए तो वहाँ चुप हो गया था. Like for some reason, I don't know, it's a mother's womb or something. Having all said and done, like, where do we go beyond this? Now, beyond this is like, we have only the, probiotics, which have the only proven therapy, which you can use for, breastfed or formula-fed babies to help the colic. Again, we have to emphasize that this is only reducing the crying time. It will not treat it, like, And the second thing is that if the child is on on a formula, then and still crying, we just need to be like, one could give a trial of hypoallergenic formula as recommended by some of the gastroenterologists. But again, you may say, okay, this is like, putting somebody to a hypoallergenic formula in absence of a documentation may be inappropriate. That's a matter of debate, but people do that, and some people find a response. If they find a response, it's worthwhile. Having said that, you should always see, are we dealing with a gastroesophageal reflux disease, and are we dealing with a silent cow's milk protein allergy, which may be masquerading as colic, and the child continues to have this kind of a thing. If everything is fine, the child is happy during the day, only crying in the night, and the gaining weight and everything fine, we understand, we are with you in that journey of pain, but I mean, we'll have to wait.
Any local Kerala remedies working, Naveen?
I think the last part which Sanjay said, I'll add one more to that. I asked the parents after I made sure that my limited physical exam to make sure there is no hernia, no bad jewelry, because Kerala children get a lot of jewelry on them, or no evident fever. If these are not there, then first check is to make sure that baby cries at night and doesn't cry in the day. So at least medically, one thing is out of my way. Second A parent who reports that baby settles down when I take him is a rascal, but when I lay him down on the floor, he starts crying all over again. Then also for me, CNS conditions and medical conditions are out of the way. Third and the last is that uh, I ask them to sometimes take them to open areas like balconies and terraces, knowing well that it doesn't work, but it reduces the loud noise which is ringing inside the house and dissipates the sound so elsewhere, and people find solace. But like Sanjay said, you'll have to literally uh, help in comforting the families in the way they want to hear it. But I have never prescribed a probiotic, more out of my dislike for that medication. And uh, colic also, I think 2 times in last 20 plus years, but not more than that. I mean, it's a honest confession. And um, I think there will be some babies who cry more. And if the formula fit, the situation is almost always bad dilution. Almost always. It is a hungry baby who's drinking only water. And if it is a formula fed, the situation is not at all what we're discussing. That is not colic. That is actually faulty feeding. But if it is a breastfed baby gaining weight, no fever, no orificial injuries, and no perineal rash, if these things have been excluded, baby cries only at night, well in the day, calms down on only, absolutely no medication, you may find solutions which parents want to hear. But like Sanjay said, I think very justified said in two statements that parents are going through their own pain and we need to find a way to help them out. And even if you look at the British algorithm, if they say that at some point of time parents feel that they're so agitated that they may hurt their own baby or they are themselves getting disturbed, then the British algorithm allows simethicone at that point. So I have never used that for that indication, but which is clearly understanding that parents can get driven to great disturbance.
Believe me, even if you don't prescribe, simethicone, they know. And they come with the bottle. By the time they reach to your or my chamber, they know that simethicone has already been given. They know that few common digestive enzymes which are available in the market, they have been used. Then only they'll come and spend money for you or me. So that part is over. And believe me, all of us will agree that there are really crying babies which are difficult to handle. And rightly said that so many times it has happened, at least not recent in the recent past, but initial days, the parents will call me on mobile that baby is crying excessive. Only one thing that I will do, just go and show it to my fellow. By the time they reach to the hospital, baby is sleeping and baby is quiet. So that gives me the diagnosis that it was a colicky baby. Car ride, as Sanjay says, for his baby, and as Minol has written here in the chat box, car ride helps. I don't know how and when and for how much time. That
I
part
think
I don't
I
know.
think it is weddling basically.
So ultimately, and then there are few local remedies in Gujarat. We have got hing application around the umbilicus. That hing roll is available from some company. They come all Naveen. They come with all these bottles. That it has
Safetida.
been done. Now tell me what extra is to be done, and then we are there to say that no, this will not work. This your baby will take some time to get better. Just wait and watch. So we stop medications rather than adding to that list. And as a pediatrician or neurologist, we at times you feel bad. At least there is a one baby in 10 or maybe in 1 month or 2 months where we feel that some support is required. Really, they are gaining weight, they are on breastfeeding, still excessive crying, and there is no reason for that. Gastritis or reflux or perianal redness, reflux formula is not required because we are breastfeeding. So there is always a, I don't know what to do with this kind of situation. And the commonest question that pediatrician has told me to ask in this group, all my pediatrician friend in Gujarat, Ramesh bhai, they told me, please ask this question to Dr. Sanjay and Dr. Naveen sir, how to tackle with excessive crying babies. They are disappointed because they are not going to get any medication for this particular problem today.
Ashish, I have got a few points. Like during my residency, we were taught that estradiol-like substances in the breast milk, they are responsible for colicky pain. So, any update about cause? Number one. Number two, why it starts late around at 14, 15 days of age and not earlier? Number two. Number three, why it is in evening and not during morning time. And as you correctly said, my 60% of the emergencies, they are colicky pain only. And finally, being an empath, it is very important to understand that for us, it's a benign condition. No cause and no treatment is required. But for mother and for entire family, it is a hell of the time. So, in fact, I vividly remember one family who used to come at night. I used to tell them that keep on shoulder, and they were not ready to go. They said that no, no, आपका हाथ लगता है तो इधर अच्छा रहता है. एक एक घंटा बैठते थे आराम से. So, in case any update regarding all these points. And finally, Atarax drops. I have seen prescription in so many babies. Why it should not be used? Throw some light. Atarax, particularly hydroxyzine.
I don't know the answer of why it happens in the evening and why it happens at 4 to 5 weeks. But what they said, it can start at 3 weeks, and by the 3 or 4 month, it will disappear. And commonly, what is been thought of, it is not the theory that has been put behind, is that that's the time where the most of the microbiome will change. The healthy bacteria which are given by the mother, they will change, they will die, and new bacteria will come up. So those baby-friendly bacteria is going to come up now at 3 to 4 weeks, and that is a change of there's a time where the change will occur, and that is the reason for this discomfort.
Does that mean, Ashish bhai, that the probiotics may help in this situation?
That is what the recent science says, but I fail. If I am prescribing, I'm only for the maternal satisfaction of prescribing. I do not have any idea whether it's going to work for my baby or not, to tell the truth. Because there is, as I told you, once in a while, baby is so cranky, they come with all these things, anticolic drops, enzymes, and these local applications, they'll come in their bag. And then I need to add to that. I'll say that nothing is required. Then they say, sir, keep baby with you. We are going. And then if baby doesn't cry, call us. I'll take them back. That is the stand of the mother. So need to do something for that. And for that matter only, these probiotics are being prescribed, otherwise not. And with a clear-cut indication that this is not going to work for your baby, this may or may not work. Don't take it that this is a messiah or this is a golden drug for all your problems. That is how Naveen or Sanjay can add to that probiotic issue. Or
Sometimes
Only
when the
because
baby is excessively crying, uh, other than this infantile colic, there might be some other serious situation. So repeated crying, all these things also we need to look
that
at.
has been ruled out. See, these are the otherwise well-growing baby. They are
Yeah.
on exclusive mother's milk. Everything is fine except crying. This is typical colic. There is no doubt about it. I always tell them that unconscious cry
Ashish
without
bhai,
any reason is colic.
I think probiotics work only because of two reasons. One is it is prescribed for 6 weeks, and second, it's very expensive. So उनको अच्छा लगता है कि कुछ तो कर रहे हैं.
कुछ कर
But
रहे हैं.
I really think that we are going in the discussion of what is called doctor-patient relationship, and we may have to exercise that on an individual basis. But most of us have covered certain things which will help our friends. 50% babies you may find are crying only at night, not in the day. And I think I have a part answer for that to Ramesh sir, but not surely whether it's perfect, because most babies have experienced night for months together, and they are finding that as the best time when they get active. During a noisy daytime when light is there, they are sleeping longer. But that is one of the reasons why babies are more active at night. This is only biologically plausible. It's not like there is a proof to that. But if baby has a pattern of sleeping in the day and waking at night, it is unlikely to be a internal medical concern. Similarly, a baby gaining weight, consoled on being handling, I would stop at that. I would really think that beyond that, it is human empathy, understanding that these are distressing situations, and would be very individualized as to how you handle the family. But
Absolutely.
I will not endorse Cymethicon, and I will not endorse, because just the way you have handled a few patients, each one of you, I have managed to handle, and some of them would have come to you, I think, because I didn't give them Siameticon or didn't give them probiotics. It's all right. We cannot solve all patients, but my personal practice, I don't use both these medications.
Mm, mm.
And
All right.
Anthrax, absolutely no, sir. Absolutely no. It is a antihistamine, and even in bigger children, it is bigger infants, it is being concerned as a drug which is not safe. And whether it's safe or not is not the question. It has been written down as not safe legally. So please do not prescribe. There are parents who are searching everything on the internet before they leave your chamber also. And they turn back and come and tell you, sir, ये तो banned drug है.
Yes.
आप मेरे बच्चे को दे दें.
Yes.
So please don't use this histamines in this situation. It will be unsafe for your
It is
practice.
only available in our country. This drug molecule as a drop is only available in our country. It is not available anywhere else. Sanjay, do you
Yes,
want
sir.
to
Ashish bhai, it is 10:30. So if all of you feel, we are definitely going to have a episode 3, no doubt about it. Right. Whether next month or after 2 months, that Nitin bhai will decide. But we are going for sure for episode 3. So you may sum up. Any of your panelists want to convey something in last 5 minutes? Because it is already 10:30.
Naveen, do you want
Good night.
any message?
I
Good.
think we have actually had a lovely discussion. There's no doubt about it. Thank you, everybody. Yeah.
Thank you, Naveen sir. Sanjay bhai.
No, I think that excellent discussion. The point here, like we want to emphasize, is that we understand that many of the things that we see in the market may not work, but we need to feel for the parent first. We have to be human first, and then a doctor, and then a pharmacist. Like, in that sequence, then you will probably do a wonders. But say, okay, this does work, this doesn't work, doesn't really solve. We need to solve the parents' problem rather than trying to say, okay, we're not an information guide, and I'll leave it there.
Yeah, see, these are never-ending discussions. You
Yeah.
have got one disease, but so many ways to treat it. One is your thorough counseling. Second is your thorough knowledge about the medications. Third is real science, and fourth is your human nature, or as Naveen says, that patient-doctor relationship. There are so many things which goes into managing those complex issue which doesn't actually any base behind it. But patient comes, and we are either a doctor or a friend or something else. So it's good discussion. There are few more issues which are debatable, which has got so many ways to treat it. And to name it simple vomitings, it can be anything under the sky. But in OPD, how will you treat those vomitings? So this is one of the clue that I'm giving to my panelists. Next time this is going to be discussed. I hope that will not take you for granted. I'll not leave you. Maybe after a month, we'll have another third episode of Pulse in Pediatrics. Many, many thanks for being with me. Yeah, I know it's late night, 10:30, both are looking tired, but really I enjoyed. Thank you very much.
No, Ashish, next time we'll come with a burp cloth as well.
Thank you so much, Ashish bhai, for wonderful moderation, keeping in mind common pediatrician. And as usual, thank you, Dr. Naveen sir and Dr. Sanjay. I mean, both of them, they are the best neonatologists, I may say, because
Yes,
in spite of being in such a
very good
stressful
human beings and
atmosphere,
very good
both of
neonatologists.
them, they are calm and quiet. I mean, one has to learn from them on a personal note. So thank you so much, friends, for attending this webinar. You can watch this on Gujarat Pediatrician WhatsApp group YouTube channel also. And a month later or next month, we'll come out with episode 3 as far as common neonatology, that is pulse of neonatology are concerned, particularly for a common pediatrician in office practice. Thank you so much. Good night. Thank you.
Thank you all.